Hi folks, this is Dr. Rob Cywes. I am the carb addiction doc. And it's interesting, about a year now, almost 2 years ago, I made a very, very powerful, highly conflicting categorical statement. And I don't mince my words, I'm not soft. So the statement I made, and I spoke about this and I published this, is that within 10 to 20 years, statins will be obsolete as a treatment for atherosclerotic plaque disease. Now, if you think about it, statins currently are the number 1 or number 2 prescribed drug in this country, and there's a massive continuous movement to continue to prescribe statins. So I made that prediction, and this video is going to explain and produce already the shift in thinking by cardiologists. But I still stick to that. Statins will be obsolete as a treatment for cardiovascular disease within 10 to 20 years. And with a lot of us, even earlier, already now. Why? Because the thinking of statins, the thinking around statins is that lipids magically and in isolation cause plaque damage to your blood vessels. And that is absolutely 100% false thinking. Because that means that lipids are trying to kill you. And the human body doesn't work that way. Evolutionarily, the human body has evolved to protect us. So the lipid molecule production is a protective thing, and it's the environment that is abnormal that they're responding to. So the lipids are doing what they're supposed to do. The problem is the injury has not yet been seen in our evolutionary process. And the injury is chronic inflammatory injury of our arterial blood vessel walls, predominantly in the heart, caused by chronically elevated sugar levels and caused by nicotine. Period. There are a few other more chronic things like lupus that you get, but those are the two. And the human body, because those are so early, has not been able to adapt it. And yes, the way the body responds to that inflammation is with lipids and plaque formation, but blocking that doesn't affect the injury. In fact, if anything, makes it worse. So the shift in thinking is rapidly happening as epidemiologic, which I hate, but as epidemiology studies start to show more effective protection from cardiovascular disease as we fight inflammation rather than plaque formation. Because the plaque is a healing response. But if you don't have an inflammatory trigger, if you don't have an injury, you don't need to heal it. Okay? So more and more the thinking is shifting toward inflammation. And quitting smoking is the obvious one, not vaping, not using nicotine. There's an obvious one. However, the biggest one in this country, globally it's still smoking, but very rapidly being affected by chronic excessive carbohydrate consumption in people who cannot clear that sugar, so rising blood sugar. And that's why CGM use, and Dexcom is coming out with a device called Stelo, which is an over-the-counter, you don't need a prescription for it, an over-the-counter CGM. Libre is going to be doing the same. I kind of like the Stelo product. It's a more accurate product. But if you measure your blood sugar, you know already what that level of injury is, what that level of inflammation is. You can predict inflammation based on your chronically elevated blood sugar level. Okay? Now, as the narrative shifts, and remember, these doctors are all primarily drug pushers. In other words, they do not consider, or really at a very low level, consider what you did to create that injury. The belief by most physicians is that we have a measurable problem, your blood works as X, and we've got a pill to treat the problem. Well, the reality is there's no medication to treat what we do to ourselves. But historically, we've used medications to treat what happens to us. So if you get an infection, antibiotics work pretty well. But if you cause the problem, A pill is not going to fix that. It may fix or it may ameliorate the consequence. But their thinking is still very heavily toward using pills to fix things. And the reason they haven't considered inflammation is we haven't really had, or at least had knowledge of or experience with, pills to reduce inflammation. We've had aspirin, we've had the blood thinners to reduce the clotting cascade. You'll see a video in a little bit on colchicine. But what you're going to see next is a video from a guy that I absolutely love in our space, Dr. Matt Budoff, who is a preventive cardiologist at UCLA. And Matt Budoff worked with Dave Feldman, the big lipid guy in terms of LDL is not a problem. Dave Feldman works a lot with LMHRs, lean mass hyperresponders, but Matt and Dave did the LMHR study that most of you are familiar with, results just published last week. Beautiful, fantastic results that show LDL is not a problem by itself. But Matt Budoff, preventive cardiologist, has completely shifted away from his traditional training toward looking at inflammation as a problem. And he's one of the more progressive, proactive cardiologists that was willing to ignore or divorce, like I have had to do, the cognitive dissidence of our training and look at the evidence through a different lens rather than spin the evidence into a known narrative. And what you're going to see next is Dave Budoff, a preventive cardiologist, talking about two drugs, one of which I completely agree with, the other one in our space I disagree with, although sentiment is there, that are primarily geared toward reducing the cause of vascular inflammation for the majority of us who are going to die of a heart attack or a stroke. Listen to this clip and then we'll break it down.
I'm Matt Budoff. I'm a preventive cardiologist, a professor of medicine at the UCLA School of Medicine in Los Angeles, California. Cardiologists see patients with diabetes about 3 times more than endocrinology, partly just because we outnumber them, but also because we see them more frequently because they not only have diabetes, they have ASCVD. About half of my patients with ASCVD have type 2 diabetes as a comorbid condition. So it's not rare, it's not uncommon. I literally probably have more patients who have diabetes than some endocrinologists out there. So it's important for us to think about it, and it's important to remember that when you have both, ASCVD occurs about 15 years earlier in patients with type 2 diabetes. So they're going to get it at a younger age. We know that in advance. So we can look for it, we can anticipate it, and we can treat it. And once they have ASCVD, their risk of having a second event is higher, their risk of recurrent stroke is higher, and their risk of death is higher. So I think all of those things add up to a very simple algorithm. You see a person with type 2 diabetes, you start thinking ASCVD. I think one of the major things that we have to recognize now is that they're all aligned, which is great. So we have the American Diabetes Association and the American Association of Clinical Endocrinology, and then we have Heart Association and American College of Cardiology. And all 4 of them are aligned now. Patients with type 2 diabetes and ASCVD should be getting a drug with proven CVD risk reduction, GLP-1RA and or SGLT2 inhibitor as part of their care. So we're all on the same page now, and that's taken some time. Yeah, and now the 5th player, if you will, is the American Stroke Association. And they've come on board now for the first time with recommendations to use GLP-1s with proven CV benefit.
Okay, folks. So Matt, a preventive cardiologist, talking about cardiovascular disease, atherosclerotic plaque, talking about 2 drugs. He talked about GLP-1s, everybody knows GLP-1s, Ozempic, Mounjaro, as a reducer of insulin resistance. And just recently, Novo Nordisk, through several studies that were done, demonstrated a far better reduction in coronary artery vascular disease by treating insulin resistance with GLP-1s than statins. So we now have 2 major classes of drugs that far more effectively, with far fewer side effects and far greater other benefits, treat atherosclerotic heart disease that are not statins. And that is why I made the statement. Now, the majority of cardiologists are still trapped in the statin era, but as they see the evidence, because the reality is millions of people in this country, prescribed and kind of under the counter, are on GLP-1s, primarily for weight loss, but we're seeing absolute, not relative, absolute disease reduction from all of the diseases that are the consequence of inflammation caused by chronic excessive carbohydrate consumption and insulin resistance. Guys, when I'm just dragging, when I'm struggling, when I've got a bit of brain fog, when I'm feeling a bit down, or when my blood sugar is a little bit elevated because of adrenaline, because I've exercised and it's not coming down adequately, that is pro-inflammatory. And you know I love my coffee. You know I like my coffee with my caffeine, but there are times when I want a combination of an anti-inflammatory, I want a combination of some caffeine for that stimulant effect, for that mind-cleansing moment that I use throughout the day, and I want to flip myself into deeper ketosis. Well, folks, the guys at HVMN, the Ketone IQ guys, have come up with an incredible product. So think about if ever you use a 5-hour energy, or if you don't like coffee, if you're afraid of coffee, if you are have a religious objection to coffee but not to caffeine, Ketone IQ has come out with a caffeine-enriched ketone product. So not only are you getting the ketone bump to help you, if you use this in the morning, if you use this when you're dragging, obviously not before bedtime, this stimulant, the value of Ketone IQ with some caffeine in it, is no different than having a cup of coffee, except you're also getting the benefit of ketones. So for those of you adding MCT oil, adding butter for that same effect to your coffee, the Bullet coffee, this is basically Bullet coffee, except it's directly giving you ketones. Try it and see. Now everybody's going to give me pushback. Whoa, 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 whoa. If you're drinking coffee, if you're doing MCT oil, if you're doing butter, you're doing exactly this. So the disease is insulin resistance, and the consequence are all of these others. And people on these GLP-1s for weight loss, for whatever reason, are seeing a reduction, seeing an improvement in PCOS, seeing an increase in in testosterone in males, seeing an improvement in mental clarity, seeing a reduction in other addictions, seeing a reduction in type 2 diabetes, seeing weight loss, seeing a reduction in GI disturbance, but if you're still eating a bunch of carbohydrates, some side effects, not from the drug, but from the consumption of the carbohydrates. And we are seeing, and I've seen for over a decade now, a significant reduction in cardiovascular risk when you treat elevated blood sugar levels. And the GLP-1 directly, it's the only drug out there that directly treats insulin resistance. Yes, it's got some side effects to it. And a lot of, you can't use GLP-1s, blah, 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 blah. Yes, it should be in conjunction with a low carbohydrate diet, but it's an accelerant if you already have disease. And the same group, they may rail against statins that have this massive harmful profile without benefit. The GLP-1s have massive demonstrated benefit, even greater in a practice like mine, which focuses very heavily on a low carbohydrate, high fat, carnivore-based diet pattern. The second drug that Matt talks about, which is the one that cardiologists kind of like because it doesn't raise LDL levels significantly, is called an SGLT2 inhibitor. And I will tell you that is an absolute contraindication in my practice, because when you are eating low carb, the SGLT2s can cause ketoacidosis. And they can kill people. They're a terrible drug when it comes to the management of diabetes or elevated blood sugar. They're far better drugs to do that. The GLP-1s I agree with. As soon as I see a patient on an SGLT2 inhibitor, the Farxigas and that kind of thing, stop the medication and let's replace it with something else. Let's replace it with a different drug because of the harm. What does it do? It gets you to pee out sugar. So you're at risk for gangrene in your groin, where the sugar's coming out, you're at risk for fluid disturbances and you're at risk for DKA, diabetic ketoacidosis. So I agree completely with Matt about the GLP-1s. That's where he's progressive. Where the cardiologists are still failing and the nephrologists are still failing is in the prescription of the SGLT2 inhibitors. And Matt and I will talk about that because he is progressive. But understand that the narrative is changing. Instead of treating the lipids that are the plaque, let's treat the cause of the plaque being there, which is inflammation. And as the narrative changes towards inflammation, we're going to be using more GLP-1s as primary care. We're going to be using colchicine. We're going to be using anticoagulants, aspirin. And that's going to be the class of drugs we use to reduce the clot, to reduce the initiation of the lipids. But the foundation still remains getting rid of the cause, which is crystal meth poisoning, low carbohydrate diets. And the reason why evolutionarily we've developed this protective system is because we've never encountered chronically elevated carbohydrate consumption in our species' lifetime. There have been episodes where, for example, the Egyptians ate a lot of bread and had some of this disease. But we've never seen this evolutionarily, so the body's never had to deal with it. But it's had to deal with injury, and it's very good at protecting us from injury, like a cut, like a wound. But when it sees vascular injury, it treats it like a wound, it reacts to it like a wound, and that makes the problem worse. So think that one through. Get rid of the cause of the inflammation, and early on, deal with the inflammation. But don't dumb down the whole system. That's why I made the statement. As the cardiologists shift away from lipids toward inflammation, and they're doing that slowly, but the evidence is overwhelming. And at some point, even the most recalcitrant, blind, cognitive dissident cardiologist is going to change their thinking. But we also have to change our thinking, which is the endocrinology problem. Endocrinologists being, at least the current methodology, the greatest enemy of a type 2 or a type 1 diabetic. And that is the narrative that you have to eat carbohydrates and that carbohydrates are healthy. More whole grains, more fruit, less red meat. We have to change that ideology. But the ideology is tied into lipids. So when they let go of lipids and they understand that it's inflammation from sugar, because let's face it, all of their patients are not eating a lot of fat. And what do they tell them? Eat less fat. Well, if I'm only eating 5 or 10% of my diet is fat and 90% is carbohydrates, it's not the 5 or 10% that's causing the problem, it's the 90%. And once they make those two connections, they will completely let go of statins. And the challenge here is the cardiologists are going to be slow adopters. The pharma companies are going to drive this narrative. Because yes, they make a ton of money from statins, but they make enormous money from the GLP-1s. Just look at Eli Lilly stock, look at Novo Nordisk stock. Through the roof. Not because of statins, but because of GLP-1s. And when Eli Lilly pretty soon releases triple G, so we've got GLP-1s, which is Ozempic, Wegovy, semaglutide. We've got combination drugs, GLP-1 plus GIP, that are even more effective, Mounjaro, Zepbound, and pretty soon we're going to have triple G from Eli Lilly. I think it's called retatrutide, but GLP-1 agonist, GIP antagonist, glucagon receptor agonist. That combination, folks, directly and very effectively treats insulin resistance. Now, I'm not a drug pusher. I'm very heavily into the lifestyle change. But as an accelerant, these drugs will help you to correct insulin resistance faster at a very low long-term cost, if anything. I'm not talking about financial cost, I'm talking about health burden. But more importantly, if you already have bad disease, while we don't want ongoing disease, we certainly don't want your old disease to bite you in the butt. And that is a consideration of how we practice. So if you're interested in working out all these nuances, if you don't know where you are, if you're doing well but you're insecure about, hey, how well am I doing? Instead of listening to some gum flapper on the internet giving you crazy advice, that doesn't understand the complexity. See a physician who works in the metabolic health space that understands this complexity and can read your blood work in the way it is meant to be read, as a story, not as numbers to throw medication at. That's what we do, folks. So if you're interested, 561-517-0642, we'll do the blood work, we'll evaluate your cardiovascular risk, and then we will uniquely to you, not in some algorithm, but uniquely for you, design a therapeutic program that eventually should leave you drug-free or close to drug-free. The goal here is deprescription, but we may need to go up to correct the inflammation to come down while you're changing your lifestyle. I am the carb addiction doc, very evangelical about this, so I get so animated. But if I've made you think, and more importantly, if I've been able to help you to save your own life, I've done my job. That's why I am a physician.